الو، السلام عليكم.
عليكم السلام. تمام كده يا دكتور حسن. تمام.
واضح.
واضح.
عليكم. السلام عليكم. بس بدخل حتى ابين اني انا موجود، متاكد معاكم خلاص ولا السلام عليكم. Hello.
عليكم السلام ورحمة الله وبركاته.
السلام عليكم بروف حسن. مساك الله بالخير دكتور حاتم.
حياك هذا حبيبي، هذا حياك الله يا سيدي.
الله حياكم الله، الله يسلمكم. Shall we start please? Everybody is hearing me.
Yes.
السلام عليكم ورحمة الله وبركاته. Good afternoon everybody. I would like first to thank all our prominent speaker, Dr. Hatim Jeffrey, Prof. Hassan Jamal, Dr. Hisham Arab. They represent, actually they are, we don't have one king for OB-GYN. We have three kings. They are all of us sharing with us in this webinar. Those three kings are from Jeddah for OB-GYN. So they are, all of them are prominent speaker. It's a privilege for me that I represent them. It's a privilege for me that I'll do this webinar with them. First, I would like to thank all the participants who are sharing with us. The number is 2,000 who are registered until now. Once we reach 1,000, it's going to be converted through the YouTube. So don't worry, proceed with the YouTube. And now I think we are reaching close to 900 plus. So thank you very much for all the participants, and this is because we have a prominent speaker, good support from Top House Conference, and good support from the company Nova Nordisk. So thank you very much, and because it's important topic. Our topic today is about update in management of severe postpartum hemorrhage, and it's going accredited by CME. And our first prominent speaker, he's always fighting for severe postpartum hemorrhage, Prof. Hassan Jamal. He is well-known figure. He is from King Abdulaziz University Hospital. He's a member of Scientific Council of OB-GYN in Riyadh. He's a president and chairman of the board director of Saudi Obstetric Gynecology Society since May 1996. He's the president of Pan Arab Association of OB-GYN Jeddah since November 2003. He's also a member of executive committee of the Saudi board since 1997. To the present, he is the examiner for Saudi board and Arab board since 1997. He is a member for Council of Asia and Oceania for Ocean Federation of Obstetric and Gynecology since in Singapore since July 2000 until present. You see, it's a history. So it's our pleasure that we have Prof. Hassan Jamal. He's going to talk to us about postpartum hemorrhage, still a major killer globally. Thank you. Welcome, Prof.
السلام عليكم ورحمة الله وبركاته، وأسعد الله أوقاتكم جميعا بكل خير. أشكر لكم هذه المشاركة، وجمعتكم مباركة إن شاء الله، ونتمنى يعني تكون الفائدة المرجوة من هذا اللقاء بإذن الله تعالى. أولا طبعا أحب أشكر الابن والزميل والحبيب دكتور سمير سندي على جهوده الكبيرة جدا في الإديوكيشن ورفع مستوى الخدمات، وما في شك إنه يعني المجهود هذا لا ينكر وكذا يعني، فالله يجعله في ميزان حسناته بإذن الله تعالى. I'm very happy and pleased and honored to participate in these topics because simply globally we're still losing mother despite this tremendous advance in the management, and we put up protocols and we did everything, but unfortunately the maternal mortality is still a major killer all over the places. I'm not talking about Saudi Arabia, I'm talking about generally speaking, we're still losing, and the majority is preventable. And this is the sadness. If something we cannot do, think about it, fine, but we can do. And I can, during my presentation, I will mention some actual story, how we lose the mother, very simply, because we didn't admit the policy and procedure in the management of these cases in the labor room. So let us start our presentation. Sorry, it's not. So as I mentioned, unfortunately, postpartum hemorrhage continue to be the major and leading cause of maternal mortality in most countries around the world. And despite the multiple at all levels, whether about the doctors, about the nurses, and adherent to the recommendation for management. I visited a lot of labor room, and they said, yes, we have the policy, we have the procedure, but there's not in the drawer. Nobody applies, can see the result and the improvement. The burden of postpartum hemorrhage is significantly greater, unfortunately, in low and middle income countries. 1/3 of maternal death from PPH occurring globally take place in the Asian and African countries. يعني بما معناه ما هم ناقصين ان هم في اوضاع شعيه واقتصاديه سيئه جدا, and they used the mother all of a sudden because they didn't have facilities, so they need help from each body. And we look to the postpartum hemorrhage definition. There is different definition and terminology all over the place in the India and so on. Anyway, primary postpartum hemorrhage is a blood loss more than 500 ml from genital tract within 24 hours of vaginal birth of a baby, or 1,000 ml after cesarean deliveries. That's the primary. Secondary blood loss more than normal local loss between 24 hours and 6 weeks postpartum. UK and other countries said abnormal or excessive bleeding occurring between 24 hours and 12 weeks postpartum. See, but we used to say 6 weeks, but now the definition have been changed. The USA guideline from the Royal College.
يبدو في تأخير شوية، ثواني لو توقف الفيديو لأنه علشان الظاهر مع الفيديو بتتأخر شوية ثواني عن المحاضرة. يبدو في فيديو بتسجيل، فلو تأخروا شوية يكون أفضل.
ما عندي
فيديو.
فيديو.
أو توقفوا. ما عندك فيديو؟
على طول حقي ما عندي فيديو.
أوكي. بروسيد يلا. شكرا.
Okay.
Okay.
So the UK guideline from the Royal College.
حسن لو تقفل الكاميرا بالفعل، هو الكاميرا مؤثرة على الأبلود حق الكلام.
كمل يا بروف، بس لو تقفل الكاميرا شوية. Dr. Prof. Hassan, he will be back again, just only a few seconds. He's going to close the video and he's going to enter again. So sorry for this interruption. Meanwhile, do you want to talk anything, Dr. Hatim, until to give us small hint or something, especially you are the most expert, until Prof. Hassan will be joining us back. Few words from...
أنا ماني the most expert. معانا هشام ومعانا بروف جمال يعني أنا طالب من طلابهم. الله يسلمك، أتعلم منهم.
You are the most expert in surgical and also you are examiner. So sometimes you are giving some hint for people who are on the exam.
Technology is
Yes,
good, but not perfect. Huh?
Yeah. It's always we are working on it. It's perfect, but I don't know. It seems that something with Prof. Hassan. So if it's going to take long time, we'll go to Prof. To Dr. Hisham Arab.
لا Prof.
Yes, Prof. Hassan. If you close the camera, Prof. Hassan, it will be great. Continue, please.
طيب بالنسبة للجايد لاين from the Royal College, from the Society of the India, the American College of Obstetrics and Gynecology, they put definition more than 1,000 regardless of the route of the delivery or any blood loss that cause hemodynamic stability of the patient. The Federation of EUIN, the Society of India, French College of the Obstetrics and Gynecology and Anesthesiology and Intensive Care, and the Royal Australia and New Zealand put that 500 ml, regardless of the route of delivery, considered to be severe postpartum hemorrhage, more than 1,000. If it is more than 1,000 severe, the other one is 500 by the definition. The International Federation of Gynecology and Obstetrics put vaginal delivery more than 500, cesarean delivery more than 1,000, any blood loss that has a potential to produce a hemodynamic instability of the patient. What about the Royal College of Obstetrics and Gynecology? Minor, as I mentioned before, between 500 and 1,000, and major is more than the 1,000. However, the volume of the estimated blood loss in these cases remain unreliable in many cases. Therefore, much attention should be directed to the clinical status of the patient, because sometimes we are underestimate the blood loss, and then we are relaxing about this. I said, no, it's not a much blood loss. No, look to the vital sign of the patient, and she might even say some words that I'm not feeling well, I am dizzy, so I have some shortness of breath. I take that into consideration and not rely on just the blood loss. Statistic on postpartum hemorrhage that each year about 14 million women experience postpartum hemorrhage globally, resulting in about 70 maternal deaths. It represents about 25% of the maternal death worldwide. And the risk factor for postpartum hemorrhage in a meta-analysis in 2022, 1, multiple pregnancy, previous postpartum, preeclampsia, fetal macrosomia, 3, failure to progress in the second stage of labor and prolonged third stage of labor. Placenta previa, placenta accreta, retained placenta, all that contributing factors. And lastly, perineal laceration, episiotomy, and general anesthesia with elective or emergency cesarean sections. And we're going to see what's more in the elective or emergency cesarean section later on. The etiology and precipitated factor of PPH. In recent years, individual authors and academic institutes have used the 4 T's to provide simplistic categorization of the cause of the postpartum hemorrhage. The first, tone. The second, tissue. 3, trauma and laceration. 4, thrombosis. So we'll start about uterine atony, and that includes the most common cause, definitely, of a postpartum hemorrhage. Reported in 60 to 70% of the cases. Unfortunately, that the majority of these cases, maybe there is no risk factors. So all well, straightforward, primary gravida, deliver normally, start to have atonic postpartum hemorrhage, and we have to start our management. Large cohort study found an incidence of the uterine atony after the first degree cesarean sections. And when you talk about the tissue, we're talking about the retained placenta account for more than 10% of all cases of a postpartum hemorrhage, and the effective uterine contraction to aid hemostasis require complex expulsion of the placenta, so it will be very effective. and that's most removal manually. 3, trauma. Trauma is reported as a primary cause of postpartum hemorrhage in 20% of the cases. Trauma to the broad ligament, uterine ruptures, cervical and vaginal laceration and perineal tear are associated with increase in the blood loss at a normal vaginal delivery. And sometimes, as I mentioned, that straightforward delivery and patient not well, hemostatically non-stable, I have to take that into consideration. Inversion of the uterus is a very rare, not rare, is a very rare cause of postpartum hemorrhage, is 1 every 25,000 deliveries in the USA, UK, Norway. To tell you the truth, and I'm over my work more than 45 years in obstetric, I've seen only 2 cases of inversion of the uterus. I haven't seen it much. And the blood loss at the delivery with the uterine inversion is usually at least 1,000 ml. For the thrombosis, disorder of the clotting, cascade, and platelet dysfunction are the causes of postpartum hemorrhage in 1% of the cases. Known association with the coagulation failure include placental abruption, preeclampsia, septicemia, intrauterine sepsis, retained dead fetus, amniotic fluid embolism, incompatible blood transfusion, abortion with the hypertonic saline. So all that existing abnormality in the coagulation system. And this is why we have to look at all these factors and to prepare for occurrence of the postpartum hemorrhage. Severe postpartum hemorrhage, the 40 rules of the postpartum and the management of that one. 4 causes for the specific causes of postpartum hemorrhage, including pathology, specific cause, and then approximate incidence. The tone is atonic postpartum represents 70%, trauma 20%, tissue 10%, and thrombosis is 1%. Is the incidence of postpartum increasing, decreasing, or the same? Definitely, as you can see it in the screen, it is increasing, unfortunately, despite all the advance and implementation of the different protocols, etc. And it represents here that the higher risk of postpartum is due to instrumental delivery. Well, we have to stop at this stage because we thought maybe a bit less because we are not using much about instrumental delivery nowadays وكده يعني ما عاد صار في الكيلد forceps والى اخره, but unfortunately it's increasing. Instrumental delivery, that means we need a good training of our resident and registrar. When they do such an instrument, they have to be experienced when to apply, when not to apply. If you need help, please don't carry on straight away about the forceps or ventouse and you end by postpartum hemorrhage. It's the highest in this group. And then it seems to be a bit less in the spontaneous vaginal delivery, and then emergency cesarean section, and then elective cesarean section, as you can see, all going up. Next. This is severe postpartum hemorrhage is increasing, and some of them, they need blood transfusion. As you can see, about 37 to 40% they need blood transfusion. And the other one also show clearly about the increase, but they don't need blood transfusion. Unfortunately, I will see a quick story here that one of our colleagues, she's a doctor, right? And she had previous 2 cesarean section, and it was placenta previa. She went to the OR in one of the major hospitals, and they saw the cesarean section, start to bleeding heavily, and they said, please give us 3-4 units of blood for her. Unfortunately, there is no cross-matching of this patient. Because they are, everybody is يعني زي ما نقول مشكلة المجاملات وكده يعني دكتورة وزميلتنا وطيب وسويت ولا وكل بس actual rules in this case you have to prepare 4 to 6 units of blood. There is no single drop of blood for her in the blood bank. So what they did, so they sent the family quickly from here and there to bring blood. Unfortunately, she died on the table, arrested. She's a doctor specialist with us, and then that's what happened. So that's just to mention about the blood transfusion importance. The etiology of postpartum hemorrhage, why the incidence is increasing. يعني ايش اللي اتغير في زي ما بقولوا في البراكتس حقنا. واحد older age pregnancy after age of 40 زادوا في العدد. high BMI, الobesity زادت كثير وهذه كلها ترى related. assisted conception technology IVF والXC زادت برضه وهذا يشمله المالتيبل pregnancy. high birth weight microsomic baby also زاد لانه برضه الدايابيتس زاد وكذا. induction of labor زاد. yes زمان كنا نخلي المريضه تقعد الاسبوع 41 42 لين تخش في لا ده هلا 40 و everybody would like to deliver a patient at this stage, and you might end by a problem because that's one of the risks of the induction of labor, the postpartum hemorrhage. Now, the epidemiology of severe postpartum hemorrhage, as I mentioned, is remain the cause of maternal mortality globally. If you take it globally, its incidence 1 to 10% of all deliveries, 80,000 maternal deaths yearly, and 800 hysterectomies from postpartum hemorrhage. That globally. What about Saudi Arabia? 1 to 5% of all deliveries, and we got 877 hysterectomy for postpartum hemorrhage per year. As we mentioned, just I don't want to repeat that again. Still the hemorrhage on the top of the list of the cause of maternal mortality, followed by hypertensive disease, and the sepsis, abortion, obstructed labor, syphilis, hepatitis, and other infections. Diagnosis of postpartum hemorrhage. The accurate assessment of postpartum hemorrhage loss remain a clinical challenge. When I can say postpartum, call for her, senior person, send out for cross matching, etc. Again, we are late. Imprecise estimation has been associated with a delay in the treatment. Yani if we have plenty of time, we talk a lot of story about how we lose a patient for the delayed treatment. And this is why I said it, preventable, if I realize it. Historically, visual estimation has been the primary method of determining blood loss. Yet, visual estimation is subjective, imprecise, and does not improve based on the provided level of experience or specialty. And to compare with the visual estimation, what to do? The quantitative of the blood loss more accurately reflect actual blood loss and is associated with improved identification of cases of postpartum hemorrhage. Now, the current method of quantitative blood loss, there is two different types. Gravimetry, the gravimetric method of weighing the blood-soaked material is based on the wet mass minus dry mass of the material being equal to the value of the blood lost. Overestimation definitely may occur if contamination with amniotic fluid or irrigation fluid is not considered, and underestimation may also occur if the blood saturated cannot be weighed, surgical drop and under-buttock drop, so drape. So it is very important for us to conclude all that in the analysis. Volumetric, it can be done using plastic drape and suction consistent with the or without calibrated markings, and the colorimetry, it quantitative the hemoglobin content in the blood, soaked materials, and account for the non-blood contaminated in its measurement mass. So to diagnose postpartum hemorrhage during managing an actively bleeding patient, one, clinician should not rely solely on the amount of blood loss, as I mentioned before, to decide starting managing patient. Two, consideration of the entire clinical picture is mandatory. Do remember that the peripartum women are young and healthy and can present late with the full pictures of postpartum hemorrhage and shock. And I'm sure all of us as an obstetrician, we see this one. Here she tolerate but she's bleeding heavily. Please don't rely that she's talking and she's okay. But the amount of blood loss is excessive, and you have to start your management. Review all the risk factors, give them more attention. Some of them you know before. Yani, wallahi, the cases, I just investigate one case, it's very sad in a patient with the placental abruption, delivered. She had a bit of bleed. The consultant went home and the patient started to bleed heavily until she shocked. They called him, he came back until they got blood transfusion, etc. She expired. You know that she is a placental abruption. She at high risk of postpartum hemorrhage. How you leave the hospital and go home? And definitely I will wait maybe 1 or 2 hours at least in the hospital to make sure that she doesn't have a postpartum hemorrhage. And she lost her life. The rule of the ultrasound scan in the postpartum hemorrhage, now that evaluation of the hypovolemic started by looking for the diameter of the inferior vena cava and aorta, and there is a useful tool in that one, and maybe Dr. Hisham Arab talk about it later on. Next. As I mentioned, that inferior vena cava and aorta diameter index has shown promise for fluid assessment in obstetric emergency like a postpartum hemorrhage. Rule of bundles and protocols in the management of a postpartum hemorrhage. There has been substantial interest in developing, implementing, and standardization approach to multidisciplinary postpartum hemorrhage care patient. And the partial safety bundle is a set of evidence and system-based recommendation for prevention and management of a common acute and severe obstetric morbidity such as postpartum hemorrhage. And update data in 2001 suggests that implementation of comprehensive postpartum hemorrhage protocol is associated with reduction rate in the hemorrhage-related morbidity. The rule of bundles we're talking about the 4R are readiness. Please be ready for this patient and don't keep it too late. It will end by disaster. The second R, recognition and prevention as much as you can from the early stage, and don't wait too long until the senior patient comes and it'll be said it's too late. The hemoglobin is about 3, her blood pressure is about 60, 70 over 45. Respond strongly immediately. That's, I think, indicate to our training, to our midwife, our resident, our registrar, how they respond immediately and to call for help for a senior patient to be around the patient, and then we can save a lot of life. Reporting and system learning, definitely when you report these cases, and I have been involved in a lot of committee to investigate about the cause of death of the, we have to report it, we have to learn out of it, because sometimes it's very, very simple thing to do. I just give a quick example that Willow's patient, when she had an elective cesarean section, she's previous cesarean, she had an elective cesarean section. Her hemoglobin before CS, it was 7. Definitely should be the consultant and the anesthesia. They said, no, sorry, she's an elective cesarean. Please push it another couple of days, give blood or whatever you want to do, but don't start cesarean and her hemoglobin is 7 and she's previous cesarean section. Unfortunately, we lost that patient. Because she started to bleed postpartum, hemoglobin 7 dropped to 3 and she arrested. Once implementation, clinician, administration, and quality improvement, experts should continually assess the bundle of effectiveness and identify deficiency in the implementation, acceptability, and sustainability of each bundle element. And that recommendation from USA 2022. What about the bigger recommendation, the last one last year, for prevention of postpartum hemorrhage? Number 1, health worker at all level of care need to have an access to appropriate medication and training in PPH prevention and management protocol. And I here talk about also not training only, also the availability of the medicine you need in a postpartum hemorrhage. When I investigate some, they don't have metergine, they don't have oxytocin in some hospital. It's a major hospital, they don't have it. If I face postpartum, how can I do? Routine active management of third stage of labor, highly recommended nowadays, despite it's stopped for years and years and years, and that's O'Driscoll active management protocol. The use of tonic for prevention of postpartum hemorrhage, third stage of labor is recommended for all births, oxytocin. And if maybe we'll talk also, Hisham, he'll talk about it. If oxytocin is not available, what to do? Use other injectable tonic, like ergometrin 200 milligram IVIM or misoprostol orally 400 to 600 milligram, or carbetocin 100 milligram IM or IV is recommended for prevention of the postpartum hemorrhage. Combination of ergometrin, oxytocin, or misoprostol plus oxytocin may be more effective strategy in some cases in setting where skilled birth attendants are not present, like a senior, to administer injectable uterotonic agent, and oxytocin is unavailable. The administration of the misoprostol 400 to 600 orally is recommended for such a patient to prevent a postpartum hemorrhage. And the fifth recommendation from Vigo, in setting where skilled birth attendants are not available, not recommended controlled cord tractions. Be careful about this one, because we tend to say controlled cord traction, yes, midwife to do it, and sometimes it may be the major cause of this postpartum hemorrhage. Sustained massage is not recommended as is not recommended as an intervention to prevent a postpartum hemorrhage in women who have received prophylaxis oxytocin. 7, postpartum abdominal uterine tonus assessment for early identification of uterine atony is recommended for all women. 8, oxytocin IV or IM is the recommended method for removal of the placenta for prevention of postpartum hemorrhage and cesarean delivery. Some they don't do all that. What about the role of anesthesia in a postpartum hemorrhage? It's very crucial. If you didn't have a senior anesthetist with you in a severe postpartum hemorrhage, you'll be in trouble. We can see their rules and the transfusion management, and we have to revise blood ordering things and fluid, and so we need a senior anesthetist from the beginning of the management of the cases. We've seen in front of us how we lose a patient because there is no good anesthetist with us. Incidence of atonic postpartum hemorrhage and related risk factors in a tertiary hospital in Saudi Arabia by Dr. Widad Al-Matairi, December 2020. It was a retrospective analysis of about 360 patients. I just mentioned to the conclusion what they did. The incidence of atonic postpartum hemorrhage in the total sample was 2.5, with rate increasing by 12% between 2017 and 2018 in a tertiary hospital in Saudi Arabia. What is the risk factors? What they discovered that the risk factors that increase the severity of atonic postpartum hemorrhage are epidural, episiotomy, induction of labor, induction supplemented with the augmentation of labor. Women who had an episiotomy, induction of labor, or augmentation are predicted to have a larger amount of blood loss, more than 1,000 ml, not in all cases, definitely, during vaginal delivery compared to the patient when are not receiving those procedures. The clinical implication of the study would be the re-evaluation of the postpartum hemorrhage risk assessment tool and considering epidural, induction of labor, augmentation of labor, and episiotomy as factors that might increase the risk score in this patient. And this will help for the early detection of the risky woman for severe atonic postpartum hemorrhage, which minimize the adverse effect of the disease and facilitate the early management of it. Future studies are needed at a national level regarding the national trends of atonic postpartum hemorrhage in Saudi Arabia with a larger sample size, so we can take it more seriously in different settings across the countries. So I hope the Minister of Health and other institutes consider the national study to ensure a good representation of the Saudi population and improvement in the outcome of the deliveries. What the complication of postpartum hemorrhage? Unfortunately, most of it is severe anemia, anterior pituitary, which we're talking about the Sheehan syndrome, or we call it postpartum pituitary necrosis, blood transfusion, and we know the risk of the blood transfusion. Unfortunately, we might lose the patient, death.
2 minutes.
Okay, I'm closing. Dilutional coagulopathy, fatigue, myocardial ischemia, orthostatic hypotension, or postpartum depression. Important message: while there exists several identifiable risk factors for postpartum, most cases occur unexpectedly, and in most cases, postpartum hemorrhage occur in women with no identifiable risk factor. So, every woman is at risk of postpartum hemorrhage. Please, as an obstetrician in the labor room, we should consider that rule. Conclusion: it's crucial that progress be made beyond the stage of simply acknowledge the problem, describing it, and emphasizing that the problem must be resolved. From practical point of view, the first step is to provide adequate training and education of the healthcare personnel in each. Please, 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 we need more training, whether the resident or the midwife. I'm repeating here because I've seen that in front of me. Next. The appropriate conclusion and area of improvement must be disseminated within the healthcare system, and the maternal mortality associated with the hemorrhage has remained the cause in the majority of the country over the last 40 years, what we are waiting for. Initial decline was noted, but has now returned to baseline despite medical intervention. This may be attributed to increase in the risk factors for postpartum hemorrhage, such as obesity and uterine overdistension. That's from the American College of OB/GYN journal in January 2020. Thank you so much for all of our healthcare workers, and thank you very much for the also the people who are arranging such a meeting. Thank you very much, Dr. Samir.
Thank you very much, Prof, for your interesting lecture. There will be some questions in the question and answer. So if you have a time, please answer for it. They will give the questions. And I'll ask all the speakers, please, to close the camera so we will have the best internet and the best transmission. We'll go for the next speaker, Dr. Hisham Arab. Dr. Hisham Arab, he is my colleague since long time. I learned from him a lot, actually. He's my teacher for CME. He's the deputy for Saudi Woman Health Society, Saudi Woman Society group. He's a senior consultant obstetrician and gynecologist. He's subspecialized in maternal fetal medicine for more than 30 years, working in assisted reproduction and minimal invasive surgery since 1995 in Jeddah, Saudi Arabia. He will going to give us a talk about medical management of severe postpartum hemorrhage. Welcome, Dr. Hisham.
بسم الله الرحمن الرحيم وجمعة مباركة. السلام عليكم جميعا. Thank you very much, Dr. Samir, for this great effort to arrange such a high caliber symposium. I'd like to thank also the organizers, Top House, and also the Novardex for their support. Okay, I'll turn my camera off if you want, or just leave it. But for the time being, I'm going to start my talk with which really the medical management of postpartum hemorrhage. The situation here start with some definitions, but I am really grateful for Professor Hassan to introduce the different definitions. For me, the only one I can really rely on or take is any blood loss that has the potential to produce hemodynamic instability is a PPH. All right. Don't go by 500, 1,000, 1,200, whatever. All right. If you have a patient in front of you who is hemodynamically unstable, you already, immediately put that red light on and proceed with the management as a PPH. Woman with normal pregnancy-induced hypervolemia increases her blood volume to about 30 to 60%, which is 1 to 2 liters. Now, a woman in a normal delivery can tolerate that blood loss of up to 1 liter, but definitely if it goes beyond that, then she'll be symptomatic, and that's why I say it's any symptomatic woman in labor should be considered as a PPH. Now, at term, we find that there is about 600 milliliter per minute blood flow that going through the intervillous space, because this is usually the site we are very concerned about whenever you talk about PPH, which is the placental site, and how the hemostasis is taking place there. Very important fact. With the time of delivery, and the only method that really controls the bleeding from the placental side is uterine contraction and retraction. All right. The contraction, as you can see, the uterus will contract, but then it has to go through the sub-evolution, and that is related to the retraction. So you have to have both procedures happening, which is the contraction and also the retraction. Because if you have a placenta that is partially separated, more likely you see contractions, but you don't see retraction. And here we have another physiological failure of closing those vessels, and the bleeding continue. You know that uterine atony leads to a blood loss of 1.2 liter per minute. So imagine if you were just checking your, lacerations or episiotomy, or asking for 2O chromic or vicryl for suturing, and saying to the patient, congratulations. Within that minute, and you had an atony, that patient has lost already 1 liter of blood without knowing, when you're turning head around. So be careful that first thing to do is you put your hand in the abdomen, make sure that uterus is contracted. Now, incomplete separation has been shown that be an important thing. And also, when you look at the physiologically, the cardiac output of a pregnant woman in labor or term is about 7.5 liters per minute. Now, 80% of that blood actually is going towards the placenta. So this is where actually most of the blood from her system is really draining, and that hole, you are leaving it open. And that's why she's bleeding heavily and she's becoming symptomatic. Physiologically, we always say a woman pregnancy is a hypercoagulable status. It's nice. But why? Why did God created a hypercoagulable status in a pregnant woman? All right. Well, the reason is for control of her bleeding during delivery. Any delivery is associated with a bleeding because there is a opening of the cervix, there is placenta separation. So God created that process to protect the woman during this stage. So she might lose some of the hypervolemia that she accumulated during pregnancy, but then she had to stop. And that process of stopping the bleeding is the hypercoagulability status. What does it include in this hypercoagulability? We have seen that there is an increase in certain coagulation factors, 7, 9, and 10. There is also increase in the plasminogen and decreased plasmin activity, which stabilizes the fibrin deposition, increase fibrin peptide A and prothrombin globulin, plus platelet factor 4 and fibrinogen. So all this to protect the woman from having a bleed during her normal delivery, and that's acceptable. It's a physiological hypercoagulability. But then when the situations become pathological, when you have lots of vessels being severed, so what we have in here, we are actually pushing what we call the pathological coagulopathy, which is really mainly creating the extrinsic pathway through the tissue factor that's been released from severing these blood vessels. Also, the intrinsic pathway through the activation of some collagen, other tissue components. And then there is also direct activation of factor 10 by the proteases released from these tissues, with induction of procoagulant activity in the lymphocytes, neutrophils, platelets, by stimulation with the bacterial toxins if they are present. Now, so this is what I'm aiming at, is the coagulopathy and the PPH. Now, coagulopathy may either be caused by the underlying obstetric complications that led to this PPH, such as amniotic fluid embolism, placental abruption, or even caused by the massive transfusion, the blood you're giving actually may lead to coagulopathy. 2, given the physiological elevation of fibrinogen levels in pregnancy, remember, fibrinogen levels in pregnancy increases, and this is also to accommodate the situation at the time of delivery. A level of 1 gram per liter represents a significant degree of fibrinogen consumption. In this clinical setting, one may wish to consider factor replacement, which is the cryoprecipitate or fibrinogen concentrate, at higher levels of fibrinogen, perhaps maybe 1.5 to 2. So aim at something like the 2 gram per liter rather than just average physiological 1 gram per liter, because you are dealing here with a bleeding blood, the body trying to compensate, so try to make more fibrin deposition to close these vessels. So you need to give that body a little bit of more of fibrin. Now, in a massive hemorrhage, transfusion targets for correction of the coagulopathy generally include platelet count. So here, what the numbers you should keep in mind whenever you're dealing with a case of PPH and you're getting the results from the lab. Aim for platelet count of more than 50, PTT, partial thrombin time, more than 1.5, even if it is doubled, that's fine. And also a hemoglobin of more than 7 and a fibrinogen level of more than 1, as you just said. Now, is this of significance? Yes. In this beautiful study, they compared these parameters in the severe group and the non-severe group of PPH. And you can see here in the severe group, the fibrinogen level is 3 compared with 4 in the non-severe one. So there is a drop in the fibrinogen level. There is also a drop in factor 2, factor 5, and also increase in the D-dimer, which is 9 compared to 6. Then also the antithrombin activity, the TAT complexes, which is actually both of them has been seen to be changing. But mainly, we're talking about here the fibrinogen. So if you want to choose one particular factor that is available in your hand to measure, is actually to do the fibrinogen level in situation where you're dealing with PPH and you want to monitor the situation. So why? Because we have seen that fibrinogen levels of more than 4 grams per liter has a negative predictive value of 80%. That means it tells you, I'm sure 80% you have no PPH problems, okay? But if you have a fibrinogen less than 2, it has a positive predictive value, which is of 100%. That means you're dealing with a PPH severity, a severe PPH, and its consequences. So a fibrinogen level of less than 2 grams per liter. So it seems to be that for each 1 gram per liter decrease in the fibrinogen, we have seen there is 2.5 chance or risk of developing severe PPH. So if that is so important, if fibrinogen levels are so important to us as a good biomarker, I mean, why don't we use it? Why don't you send it to the lab? Well, I can assure you, you can send it to the lab right away, but the lab will tell you, I'll give you the result tomorrow or after. Sorry, I cannot give you an immediate result. So for that reason, the researchers on this area, where they want immediate results of fibrinogen to assess whether we are dealing with a severe PPH with its consequences or non-severe, then they have established what we call the point of care testing. This is a technology which is called the viscoelastometry. This is a well-known technology used in biomedicine, where they have looked at tissues elasticity and they measure the different type of components. It has been used in breast cancer, it has been used in other tissues, and now they are really trying to apply it in the clots. So they take the blood from a woman with this situation and they wait for the clotting and then look at the viscoelasticity of this clot or of this thrombus. That's why they call it the thromboelastometry. And from there, they can tell you the level of fibrinogen. Well, they did, in fact, and they have seen what we call the CA, the clot amplitude. So they have correlated the clot amplitude with the fibrinogen levels beautifully. I mean, they can correlate, I mean, very nice. And they call it point of care because this test can be done within 10 minutes. So I really urge every hospital or every maternity unit should have this machine, which really help to monitor your cases of PPH and give you immediate results of the fibrinogen level just to see where you are. And you can repeat the test. You know, after a half hour, the patient continue to bleeding, send another sample for this point of care fibrinogen level assessment, and you can get a result immediately. So this is something really new, developing, and I think it is coming up as the ROTEM or the FIPTUM. This seems to be there are four main things that we need really to assess in cases of postpartum hemorrhage. And this is really not me saying this, it's the recommendation of the International Society of Thrombosis and Hemostasis. They recommend to do the PT and PTT, platelet count, and also this point of care fibrinogen with the ROTEM or the TEG, and of course the fibrinogen. So from here, we can see it's also now becoming an international recommendations to have this point of care testing available in your maternity ward anywhere you are. Well, from this, the hematologist and other scientists actually has put even what we call an algorithm or a protocol for the use of this point of care ROTEM and assessing of the fibrinogen level and as during the management of a case. And they tell you, for example, if you have a blood loss of more than 1,000 ml or a stage 2 of activated fibrinogen fibrolysis, you give tranexamic acid. Whether you give it or not, you should take the blood and do that point of care ROTEM, which is the elasticity of the clot formation. And accordingly, then you just follow these. I want to take on these very minute details. Maybe even a hematologist maybe can sometimes really can explain these numbers, and they can guide you with the management of this. But it is something of help. It's something very clearly, studied. And actually, as you can see, you just follow the algorithm, and you can save your patient. It tells you whether you should give medication or whether you should give blood or blood products like fibrinogen and or concentrate, or even sometimes maybe you tell you just go for surgery. With the use of this, actually, in introduction of this point of care ROTEM, we have seen that the requirement of blood transfusion has decreased in many centers in the world. And as you can see here, the blue line where you can see the fresh frozen plasma, or the dark line, which is the RBC transfusions, has decreased over the years for 2014 till now, is showing really marked decrease requirement of blood transfusion, which is something that we are really actually hoping for, because this is what we call now the patient blood management, the PBM, which is a very important aspect, and I'm going to discuss throughout my talk. Now, approach PPH with a PPH. I like abbreviations. So postpartum hemorrhage, you approach it with a PPH, but it's called predict, prevent, and handle. So the first P, which is predict, that means you have to identify, or at least know what are the risk factors in your patients and whether she is at risk of having a PPH. And of course, we heard it from Professor Hassan Jamal, the 4 T's, the tone, the trauma, the tissue, and the thrombin, which is really listed here. That's one way of assessing your patient. That's a first step, whether to qualify her as a risk patient for PPH or not. Then seek multidisciplinary consultation if she is. So you're already alarming your hematologist, already alarming your anesthesiologist, and even the rest of your team. All right, get the midwives involved and the nurses and the team aware of the situation you're dealing with. And then, of course, one of the prediction of PPH is actually, we do it some way before, which is optimizing the hemoglobin levels before delivery. Don't bring a patient to delivery room with a hemoglobin of 8 or 7. Really, this is a poor antenatal care, and it's not really nice. Now, approaching the second P, which is really prevention. Now, to minimize the risk of PPH, Cochrane reviews had actually shown that the proactive management of the third stage of labor, which consists of prophylactic administration of uterotonic agents such as oxytocin, capitocin, ergometrin, has very successful in preventing PPH. So it's not a treatment; it's a prevention. You give it during the third stage of labor. We just heard it. I'm going to talk about it in a little while. But more important, in fact, is, as I just said before, prevention of preventive iron supplement during pregnancy to prevent iron deficiency and iron deficiency anemia actually has really shown to be very effective from 60 to 70%. And for every patient, I advise any doctor following up antenatal patients really at 30 or 32 weeks of gestation, do hemoglobin. And if it is less than 10, of course, you should do the serum ferritin and you should give her intravenous, 1 shot of intravenous iron. And this is actually came as our recommendation of the management of iron deficiency and deficiency anemia that was published in 2019 as a Saudi guideline recommendation. Okay, again with prevention, we have the prophylactic measures that has been mentioned. This is the FICO recommendation, by the way. And you can see the FICO recommendation has 2 halves. One half is for prophylaxis, which is really circled in the red, and then the treatment. But if you compare the two, they are the same, actually. But it's very important to be ahead of your patient, ahead of your PPH anticipation, all right? Identify risk factors, treat anemia antenatally, and then active management of labor. Of course, the uterine massage and all these things can help in the beginning. It may not do anything once the PPH has already set in, but as a prophylactic in the beginning, of course, it becomes very helpful. Postpartum monitoring, that's very important, looking at the perineum and the blood loss. So this is how really the prevention. And then handling the PPH, the H of the PPH, predict, prevent, and handle. I will try to send you some messages here every now and then. Blood loss is commonly underestimated. Well, in order to handle a PPH, you have to identify your patient. Is she really really bleeding or not? Okay, and the problem is we always tend to underestimate the blood loss. We heard it from Professor Hassan Jamal about the visual, gravimetric, and direct measurements calculated. Even there are formulas to calculate blood loss, but we have seen that most of them, they don't work. Maybe I'd like to share with you now some kind of artificial intelligence technique. It's called the colorimetric blood loss. And here, this is the 2021 publication. It came as an artificial intelligence that helped estimating the blood loss. All you need to do is just to download an application on your phone and go around, take a picture of every sponged or soaked tissue that's come out, the bottle or the container that contains, or the suction bottle that contains the blood there, take a picture of it. This actually, the application can calculate for you exactly how much RBC is being really set in these pictures. Somehow it's really having a very good correlation with reality. So this is something new to learn about artificial intelligence, helping you estimating the blood loss rather than just the visual and other procedures. I'd love this to be actually, included in every single birthing unit, which is really the brass V, because if you really have this under the patient during the normal delivery, then everything come out of the vagina will be sitting in this bag. But I've seen that bag sometimes being folded somewhere under the patient, which is really, really hilarious. But make sure that use this bag properly. What we call the V drape can help really also accumulate all the blood that's being lost. Now, I told you about the approaching PPH with PPH. Now, handling the PPH also with PPH. Now, there is something bad handling PPH, and there is a good handling PPH. Handling the PPH with this P, panic, H, hysterectomy, is a bad handling. Okay, don't panic and rush into hysterectomy. That's really bad. So what you need to do is to use the other PPH, P for Pitocin, which is the syntocinon, P for prostaglandin, and H for a hematologist. Of course, this is the area that we really need to be looked into carefully. I mean, Pitocin and prostaglandin, this is in our hand. This is what we are capable of. But there are other measures and other actually holistic pictures that need to be assessed in this critically ill patient where you need the help of anesthesiologist or maybe hematologist in a situation like this. So, I'll talk about the medical therapy. We just heard in Professor Jamal about the first-line therapy, which is the oxytocin and also the ergometrin. If you want to give also the carboprest, or that can be of help, Pabal. We all know about the doses. This is like on a daily basis. So as I said before, we use this even as a prophylactic. Of course, the patient still bleeding, still you can give more doses of this to make sure that you're controlling. Again, another light or another bulb I want to put on here. Beware of trickle and moderate lochia. We tend to underestimate things. We want to go back, we want to go home, we want to go shopping. Oh yeah, just a little bit of trickle there and you leave. Or moderate lochia. Yeah, yes, it's not normal, but moderate lochia. Well, these are the areas where actually ended in postpartum hemorrhage. So we have to use what we call the adjuvant agents. Adjuvant agents, the first one of them is actually the tranexamic acid. Tranexamic acid is a beautiful drug that can be given 100 milligram intravenously over 10 minutes. But unfortunately, you can give it only once at the time of the setup. You have to repeat it. You have to wait for 24 hours to do that. But then we have also what we call the recombinant factor 7 activator, which is basically this is the physiological factor 7, but it's being synthesized, and that's why we call it recombinant. And it can be given also intravenously, about in the 50 100 microgram per kilogram as a single dose. But this one can also be repeated. Depends on the situations and also under the guidance of hematologist. Another light bulb here says minor PPH easily progress to major PPH. Keep this in mind, because don't again underestimate the blood loss. Or you see just as a minor, because within seconds this can be a major PPH. So what about the management sequence here? We can see that the stage of PPH started as very little, but then severity can increase to a stage where it cannot be controlled. Of course, we're using the oxytocin, prostaglandins, or methylorganovins, that's fine. Giving tranexamic is good. So we have to use all this. But then they put you at the stage where, what shall we do? Blood transfusion, put a Foley catheter in, large bore IVs, and alarming all the staff. Of course, that's essential to be done. But then it comes to the areas where we can need the help of hematologists, for example, or surgeon to do maybe some kind of surgical approach. And this is what really Dr. Hatem, inshallah, will tell us about. However, it's very important that we need to examine your patient, remove placenta parts inside, examining the cervix and the vagina and the perineum for lacerations, for bleeders. So this is the ABC that we always do, but I mean, we have to keep on top of it in order to monitor all these things. As I said before, with all the blood tests you send, maybe every half hour you send a blood test for these patients. Okay, plasma fibrinogen more than 2 grams. Platelet more than 50, and the pH is more than 7.2. So all these situations have to be really monitored carefully. And here I come to the most important, the drug that really of help in case we have. This is a not first-line medication, by the way. You do, I just mentioned earlier, you do everything, your Pitocin, your prostaglandin, tranexamic acid, immediate kind of maneuvers or surgical things. Even you can do surgery before you give this medication. But The recombinant factor 7 actually is very important because it is following just a physiological changes in the time of the of bleeding. So the recombinant 7 actually works locally at the site of the vascular injury where tissue factor is exposed and activated platelets are found, and hemostasis is induced by two mechanisms. One, the direct activation factor 9 and factor 10 becoming active factor 10, which really stimulate the conversion of factor of the tissue factors into prothrombin to thrombin. You can see here, according to this diagram I put for you just to understand easily, where normally this is the coagulation cascade. Tissue factor activate factor 7, factor 7 activate factor 9 and 10, who actually convert prothrombin to thrombin. Thrombin actually convert the fibrinogen or make the fibrin clot more stable. Now, initiating the coagulation cascade with the key final steps being activation of prothrombin to form a thrombin that results in a cleavage of fibrinogen to form a very stable fibrin plug, and this is what we want. So we here now, we are apart from all the hemodynamic status and from the contractility of the uterus and from replacing the blood loss and all this, now we are going to the site of bleeding in whatever area it is within the uterus or anywhere else, I mean, where we give this medication to reach there to form a plug. Now, of course, at the pharmacological doses, the recombinant factor 7 directly activates the factor 10 on the surface of the activated platelets of the site of the injury, independently of the tissue factor. Here, we don't need a tissue factor because this is a tissue factor. This is the product of tissue factor activation. This results in a thrombin burst with conversion of the prothrombin into the large amount of thrombin and the local formation of a stable fibrin. The dosage is usually 90 microgram per kilogram. This is based on just consensus levels, but is usually for 50 to 100. I mean, when you calculate it, becomes about 6 to 7 milligram. There should be the heightened awareness that the risk of thromboembolism, because you are creating a clot here. So one of the side effects, and that's why people are scared of this medication, is that you may cause thrombosis somewhere else, not just at the site of the bleeding. Well, consideration of the use of recombinant 7 in PPH must take into account the efficacy, the side effects, and the cost, of course, versus other medications and other products of hospitalization. But concerns regarding the cost of factor 7 activated factor medication can be neutralized by the saving in the excess blood transfusion, reduced operative procedures, and like hysterectomy and its consequences, and also in centers where no resources exist to conduct arterial ligation or radiological embolization, you can give this recombinant factor 7. This is just like a guideline that has been produced by the Australian group, where it shows you how you really manage these postpartum hemorrhages, from medical intervention, I just mentioned, then to blood component therapy, to surgical intervention, then sustained postpartum hemorrhage. So you've done your medical, you've done your surgical, but you're still seeing bleeding, trickling and coming. Patient is still not stable. So here, where you consider the recombinant factor 7, activated factor 7, and actually once you give it over 10 minutes or 3 to 5 minutes, sorry, then you wait for 20 minutes. If no response, check in to optimize the temperature, acidemia, calcium, platelet fibrinogen, and also you may then can administer a second dose. But as I said, this should be handled with the help or with the assistance or guidance of a hematologist standing by you, so we can obtain the best out of it in general. In order to check the efficacy of this medication, Novo Nordisk, actually the company that's producing the Novo 7, has their own collaborators from 7 parts of the world, from Switzerland, France group, and then the Danish and the UK group, then from Bern University, my friend Daniel Surbuk. He's leading a group there in Bern. And then, of course, from Australia, New Zealand, and then the Czech Republic. So they all actually looked at the outcome of using the Nova 7, and they found they put as an outcome, primary outcome, which is really reducing the incidence of invasive procedures. All right. So as really a primary outcome as a result of using the Nova 7. But then they have put another secondary actually endpoint, which is really they evaluate the thromboembolic events and the consequences out of it, side effects. When you looked at the Bern University, Daniel actually reported that the yes, there was a decrease in the incidence of invasive procedure, and you can see here the non-Nova 7 used 31%, while in the Nova 7 used group was only 16%. Similar findings was in the Danish and UK group, where they found also reduction from 58 to 35% in the incidence of procedures, invasive procedures. Then the same from Australia came out to say that 35% had and 65% did not have invasive procedure after giving the Nova 7. So it shows you here that it really has met at least its primary goal to reduce the invasive procedures, blood transfusions. And at the same time, when they looked at the secondary point, which is really the complications, they found that the fewer patients with hysterectomies in Nova 7 treated the reference group, and also less blood transfusion was received in the Australian group. The median duration of bleeding actually been shortened, so they have been shown in the Bern University and also in Australia, and also 74% actually regulation or control of the bleeding as reported by the Australia. VTE and ATE, actually venous thromboembolism and arterial thromboembolism incidence did not increase in those treated groups in all centers. This is the secondary endpoint, where they're actually looking at the number of transfusions, and you can see this from the in the UNICEF, which is in the Czech Republic and in Australia, they have number of units has decreased from 9 to 4.3 after giving the blood after giving the Nova 7, from 11 to 6 in the Australian. And this is just about the last slide about the safety and of this Nova 7. And you can see there has been report of 13 maternal deaths who had actually received Nova 7, but they are sick patients with PBH at the same time. But they did not find one of them related to the Nova 7 itself. All of them has been related to a death like emergency cesarean section with vaginal deliveries, about 7%. So the cesarean section was really contributing higher to the death here. And also the assessment of the preterm deliveries can be contributing to this. Uterine atony was a major contributor, and so on. So it shows you that none of these 13 reported this in those Nova 7 used group in the 5 centers that been enrolled in this collaboration was not related to the Nova 7 itself. Before I want to close, actually, I thought maybe there is an area, I don't know who should cover it, myself or Hatem. The balloon, is it surgically, Hatem? I don't know. But it is a very, very important thing, really. You have to learn, you have to master. So if you are dealing with postpartum hemorrhage, and this is can be handy. Yes, the balloon can be very expensive. You can see all different kind of balloons, the Bakri or the Sengistekin or the CAT or the hydrostatic. You can see the cost here ranging between $80 and $200 and $250. Okay, but at the same time, in Bangladesh, they actually did this balloon, did the same thing, and it cost only $5. All right, so you can use the condom, you can use the glove, and you can fill it with saline, push it inside, and it may do the same work as Bakri or those expensive balloons. So anyway, this is the balloon story. And if you want to look at the efficacy, this is in this meta-analysis, they had really looked at the uterine balloon tamponade success rate was 84%, comparable or similar to the arterial ligation. So, and not far away from the embolization and the B-Lynch technique, which is about 90 to 91%. So again, it's a very good technique. Sorry, Hatem, I covered this. Maybe I leave the actual nitty-gritty stuff of surgical techniques for you to discuss. And I'd like to thank you very much all. Thank you.
Thank you very much, Dr. Hisham. There are some questions actually in the chat. We'll keep it at the end. So if you have a time, please answer it. Then we'll keep some of the questions, important thing, at the end. I'd like to welcome Dr. Hatem Al-Jifri. He will talk about surgical management of severe postpartum hemorrhage. And Dr. Hatem Al-Jifri, he's a consultant of gynecological oncology at the Department of Obstetric and Gynecology and Oncology in King Abdulaziz Medical City, National Guard, Jeddah, since September 22, 2002. He's a chairman of Gynecological Oncology Tumor Board at the Department of Oncology since September 22 also, 2002 until now. He's the head of Gynecological Oncology Section and Oncology Department at Princess Noura Oncology Center, KMC Jeddah, from 2009 until now. Welcome, Dr. Hatem Al-Jifri. We are ready and want to have to hear the active surgical management as a surgeon. Thank you.
Shukran. Thank you very much. It's an honor to be with Professor Jamal and Dr. Arab. This is the outline. I'll have lots of pictures actually, so we'll try to go quickly. This had been covered by Professor Jamal and by Dr. Arab, but definitely I want just to emphasize this. It is the bleeding of that causes the instability of the patient. Hemodynamic instability of the patient is the one that we want to look at. This is a very nice table. By the way, I'm going to send my lecture to Dr. Samir, and all participants can have it as a PDF file. This is just an estimation how much the blood loss and how that will be affect the vital signs of the patient. Again, definitely that depends on the reserve of the patient, her health, hemoglobin level, intravascular volume prior to the bleeding episode. Again, the 4T that had been mentioned many times previously, but this is also the same steps we are going to use surgically. Okay, the trauma, the tone, and the tissue, and the thrombosis or the coagulopathy. This is something also nice. You can print and you can leave it in all labor and delivery rooms, just as a reminder for people who are facing these episodes of bleeding. Okay, this is something very important as well regarding the surgical approach to the postpartum hemorrhage. You can start by having this acronym, as said by Dr. Hisham. Stasis: shift the patient to the operating room while you are doing the combined compression. The trauma, sorry. The trauma, the tissue, the tissue lacerations, I mean, and the tamponade effect by compression or by balloon. And then we are going to talk about the systematic devascularization starting from the uterine artery. Lots of literature talking about this type of uterine artery ligation by name of O'Leary. I don't know who's O'Leary. I've never heard of him before. Also, we should talk as well about the radiologic intervention. Then, الأخيرة subtotal hysterectomy. To be honest with you, I don't recommend subtotal hysterectomy, but I'm just going with the acronym of stasis. So shift tissue, apply systematic intervention radiology, and then hysterectomy, or as mentioned, subtotal, but don't do subtotal, please. طيب, this slide is a summary of all surgical approach to the postpartum hemorrhage. And to be honest with you, I really would encourage all residents, fellows, junior staff with us here to print it and also to have it in their tablets or their smartphones as something to remind themselves about what are the steps to do. And I'm going to talk about simulation at the end and the importance of these emergency drills every now and then in every hospital, especially small hospitals, especially periphery hospitals, especially hospital with a small number of staff, to have this, what we call emergency drills for postpartum hemorrhage, and to go over these steps. And I can tell you from personal experience, it will be very bad, very bad. You start your surgical intervention and you are looking for long clamps. You are looking for long clamps. You are looking for large packing instruments. All of these stuff, if you don't have it ready, it will be a waste of time. Cystoscopy, have the cystoscope in the room at the end of the surgery. Maybe you need really to look at the bladder and to look for, to test for the ureter integrity. Ultrasound, bedside ultrasound, okay? And you should have actually what we call emergency kit for cesarean hysterectomy, or what we call it in our hospital, gynecology oncology set for hysterectomy, that has all the long instruments. It will be very bad in a hospital that you go to the labor and delivery room, operating room, and you ask for long instruments, and all what they have is Babcock and maybe just small clips or snaps. You look for Heaney, they don't have it. So it's much better to have that kit available all the time. Like lacerations. The idea of this picture actually, is just to see the relation of the ureter and the uterine artery and vein. Okay, so this is the ureter and the uterine artery and water under the bridge. We will have a real picture soon. So when there is a laceration, as you can see, that you start your locking suturing, okay? That's will control the bleeding little bit, but you have really to ligate that uterine artery up and down. But remember, ureter is here somewhere. So you have to understand the anatomy, as I'm going to show in a second. Another laceration common is the cervical laceration. So what you need to do, actually, you have a good speculum, as I mentioned there in the previous slides, good lighting, good retractors, big speculums, and you start with the ovum forceps in a systematic circular examination of the cervix. So you put the two clamps here, and then you examine that area. Then you put a clamp here, and you examine that area. Then you put a clamp here, and you examine that area. And then if there is a laceration, you suture it immediately. Compression. The whole idea of the compression, actually, or the tamponade, is to mimic the normally contracted uterus. So the whole idea is just to minimize the bleeding by contracting, either by tamponading from inside or by compression from outside. This is the balloon Dr. Hisham اتكلم عنه. And these are the types. You don't need really to have زي ما قال Dr. Hisham, the expensive one, okay? There are many types. طبعا هذا البكري بالون حق يونس بكري, the gynae oncologist اللي كان في التخصصي. This is the Sengistakian tube حقت esophageal varices استخدموها حقون الجنرال surgery. And this is what we call the condom catheter. That's you can ligate the condom, as Dr. Hisham mentioned, on the top of just regular catheter. طيب, you just put silk or whatever, you tie it, وبعدين you inflate the condom. And actually another trick is to use a 30 mil urology catheter. ما في عمليات ما عندهم 30 mil urology catheter. You insert in the uterine cavity and you inflate 30 cc, 40 cc. Actually, the balloons can tolerate أكتر من كده. So you can use just a simple 30 cc urology catheter. طيب intrauterine packing it is something that I've never seen صراحة, لكن موجودة في الكتب. I'm going to mention that. And the whole idea, I'm bringing this picture about the use of the packing itself. طيب أباكم just to look at this packing technique. As you can see, it is folding. Okay, it is fold. That's for the uterus, but I'm talking about also packing the pelvis. قبل شوية كنا بنتكلم إنه sometimes your surgical bleed will become medical bleed. طيب after massive transfusion without monitoring the coagulations and without giving cryoprecipitates and frozen plasma, your patient will start to bleed medically, not surgically. So sometimes maybe you need really to pack the pelvis after the hysterectomy and to send the patient for resuscitation and to improve the coagulopathy and to come to fight in another day. So while you are packing the pelvis, you can use a very long packing sponge أو إنك تربطها. But the whole idea is just to do it in what we call hadil folds. So you can put it for the pelvis and then you build it in folds, and it works like magic. A second way surgically to control the bleeding اللي هي devascularization in a systemic step. So you start by uterine artery here. You can go down main branch حق uterine artery. I'm going to show it to you. You can go to the connection between the tubo-ovarian ligaments and the uterus. Also, that will be a source of good amount of blood that you can cut by doing bilateral. طبعا when we do it, we have to do it bilaterally. Okay, this is also another picture. You can see the area of ligating these two vessels. Okay, I want you now to look at this picture, and I want you to monitor this or to look at this. Just a second, I'm going to take this. Okay. Had the uterus. This is the posterior wall of the uterus. This is the ovary. This is the fallopian tube. This is my hand, and this is my hand. I want you to see, this is the ureter. And this is the uterine artery. طبعا my hand is pulling the ureter closer to the uterus. Usually in real life, a ureter away من the edge of the uterus by 2 centimeters, but my hand is pulling. This is a much closer picture. As you can see, uterine artery, and this is the ureter. Water under the bridge, that's uterine artery. Okay, so when you want to do the devascularization and you want to suture the uterine artery, keep in mind that you have to visualize the ureter. How to visualize it? We will talk about it in a second. طيب. Another picture, same thing. You can see the ureter. You can see the uterine artery. لكن there is something that very few people know, except in gynecologist. Water under the bridge, it means that the uterine artery crossing the ureter. لكن believe it or not, a uterine vein, it is usually underneath the ureter. Uterine artery crossing above the ureter, and the uterine vein is crossing underneath the ureter. And that could be a source of bleeding, especially if حالات hysterectomy or after hysterectomy if you don't catch it. طيب, B-Lynch suture. I'm going to talk about the technique. Dr. Hisham showed the efficacy تبعتها, لكن I'm going to talk about the technique, and keep in mind about the 3 centimeter أنا بس بحاول أحط طيب ما أعرف ليش القلم حقي ما هو راضي يكتب الآن. طيب, keep in mind the 3 centimeters, we'll talk about it. 3 centimeters up or down من الانسجن. Okay, so you take you take it 4 centimeters from the edge medially, وبعدين you insert the needle 3 centimeter from the edge medially, sorry 4 centimeters medially, 4 centimeter هنا 4 centimeter ممكن تكون، لكن أهم شيء عندنا 3 centimeters underneath الانسجن 3 centimeter، وبعدين نطلع above the incision 3 centimeter. Okay, في صورة ثانية توضحها أكثر. So what we do, we start from anterior, we go inside the uterus underneath the incision 3 centimeters، ومن جوا 3 centimeters from inside 3 centimeters above the incision we come out. So we went in تحت الانسجن 3 centimeters جوة اليوتراين cavity, we came out from the uterine cavity 3 centimeters above the incision, and then we take the suture around the fundus. When we take the suture around the fundus, we go from posterior wall inside the cavity again. وبعدين جوة الكافيتي we go lateral, sorry, to the other side, and we go out from the inside out. And we put the suture around the fundus. وبعدين ندخل من الانterior wall 3 centimeters above the incision جوة اليوتراين cavity. And from the uterine cavity, we come out 3 centimeters below the incision, and then we tie in front. This is the picture. Okay, 3 centimeters in, وبعدين 3 centimeters out. نلف حوالين الفندس, and we go inside. Once we go inside, you can see that we went inside the cavity, and then we went outside the cavity, around the fundus, and then we come inside again 3 centimeters above the incision, and from the inside of the uterus, from the uterine cavity 3 centimeters above the below the incision, and then we tie. This is the tie. Okay, you can see it here. Sorry, are you talking to me? Seems maybe a mistake. طيب. This is another picture, as you can see. طبعا هم بادئين هنا من اليسار, لكنها you can do it the same thing. So 3 centimeters below the incision in. طيب. And then 3 centimeters above the incision out. Go around the fundus. تدخل from posterior inside the cavity. And then we go outside the cavity. And then around the fundus. And we go in again 3 centimeters above the incision. From the inside, we come out 3 centimeters below the incision, and then we tie. And this is how it look at the end. Okay, these are the suture, as you can see. Okay, my advice to all residents here, all junior staff here, go and buy some of these simulation socks. إذا حتى ما عندكم socks, you can use it. You can create it yourself at home and try to practice this Lynch suture at home again and again. طبعا there is a catch with the B-Lynch suture, that if you are not compressing a uterus while you are tying, your assistant should compress the uterus while you are tying. Otherwise, your suture, maybe it become ineffective, or أسوأ, it will lacerate the uterus. So you need really to compress, and then you tie. This is another way actually that you can do suturing مع اللينش أو بدون اللينش, that you can طبعا اللينش, as you remember, إحنا we are tying, so we are bringing the uterus from tall to short, shortening the uterus. لكن you can use another technique معها ممكن أو بدونها, that you do the same in and out, and then you tie. So what you do actually إنك أنت you are thinning الwidth, عرض اليوترس. Okay, you are going to decrease the width of the uterus. This is another suture. It is more effective actually, and to be honest with you, with the in the case of the bedside bleeding, placental bed bleeding, it will be much better to use this suture. أنا ما أعرف إيش القلم حقي كل شوية أوقف، معليش اعذروني. طيب, you can use the suture. Okay, maybe now it's working. From anterior posterior wall by creating this squares. All what you do, you are opposing a wall of the uterus, an anterior posterior wall of the uterus together. طيب, internal iliac ligation. Internal iliac ligation الحقيقة it is something that we do. When we do internal iliac ligation, we have to do it bilaterally, and the whole idea is just to decrease the hydrostatic pressure of the blood supply to the pelvis. There are lots of collaterals, so we cannot cut the whole blood supply. ما حنقدر to cut the whole blood supply to the pelvis حتى by tying bilateral the internal iliac artery. لكن doing a bilateral internal iliac artery ligation, actually it can be a life-saving maneuver, especially before or after a hysterectomy. So you should really learn how to do it, وحنتكلم عنه بعد شوية. Especially if there is bleeding بعد الرupture, or bleeding is in the broad ligament or in the vaginal angle, or in an area that is very difficult to control الحقيقة. Before doing the packing, maybe you need really to do internal iliac artery ligation and do the packing after that. There is a catch, وهذا يجي في الاختبار دائما السؤال ده. When we do ligation, we have to ligate the anterior branch only. We cannot ligate the whole internal iliac artery trunk, including the anterior and posterior branch. ليه? Because of this guy. طيب, البوستيريور برانش طبعا العشرة برانشز حقت الانتيريور، لكن 3 في البوستيريور اللي هي I love Saudi Arabia, iliolumbar, lateral sacral, and the most important one is the superior gluteal artery. Superior gluteal artery supply is the blood supply, main blood supply to the gluteus maximus muscle. فواحدة من الأشياء يعني خصوصا about this artery, it is the only artery في pelvis that does not have collateral. So if you tie it, the patient will have gluteus maximus ischemia or even necrosis. So you have to avoid the posterior branch. You have to avoid the posterior branch of the internal iliac artery by taking your knot 1.5 centimeters away from the bifurcation of the common iliac artery, like this. This is the common iliac artery. This is the external iliac artery, and this is the external iliac vein. This is the internal iliac artery trunk. This is the anterior branch, and this is the posterior branch. So when you want to do the internal iliac artery ligation, it is very difficult to see the posterior branch. لأن posterior branch يطلع posterior تماما. It's very difficult to see. I've seen it very few times. I'm in the pelvis in and out, لكن very few times, وحتى بالروبوت الآن بس بنشوفها. But it's very difficult to see the posterior branch. So what you need to do to avoid the posterior branch, عشان to avoid the superior gluteal artery, you go 1.5 centimeter away from the bifurcation of the common iliac, and you tie here. تقريبا هذه حتكون 1.5 centimeter, 2 centimeter will be fine, and then you tie, you apply your knot here. Again, it's just showing you the relation between the ureter and the internal iliac. Again, this is very important picture. Very important picture. اليوريتر تطلع من الرينال pelvises, go retroperitoneally, lateral للIVC في اليمين, lateral للأورطة في اليسار, and it jumps in the pelvis at the pelvic brim at the bifurcation of the common iliac artery, and then it follows the internal iliac artery all the way in the pelvis. I'll show you in a video لو كان عندنا وقت. And it enters the trigone after crossing في الباراميتريوم تحت اليوتراين artery وفوق اليوتراين vein. When we want to tie the internal iliac artery, remember that there is a vein here. You want to avoid اللي هو external iliac vein while you are putting your right angle, and you want to avoid tying the ureter, and you want to avoid the posterior branch, so you tie 1.5 to 2 centimeters away from the bifurcation of the common iliac artery, and you put the clamp from lateral to medial. هوريكم الآن. That's one of my patients. I want you to look at the ureter here. Let me just try to see if we can change the color. طيب, that's the ureter here. That's the external iliac artery. That's the external iliac vein. That's the internal iliac artery. And this is here the obturator nerve. So you want to avoid the vein, you want to avoid the ureter, and you want to avoid the posterior branch of the internal iliac artery by going 1.5 to 2 centimeters away from the bifurcation of the common iliac artery, like here. As you can see, this is the ureter here. Okay, and this is the common iliac artery, external iliac artery, internal iliac artery. You take the anterior branch and avoid the posterior branch. And when you insert your right angle, you come from lateral to medial. Why we come lateral to medial in that direction? To avoid the vein. Remember the vein? So if we go from inside to outside, the tip of the right angle will catch an external iliac vein, and you don't want to injure it. Believe me, you don't want to do that. Right. This is another important picture في laparotomy. This is بحاول أكبرها دحين بعد شوية. This is the ureter داخل البلفس at the common iliac artery bifurcation. So what will happen here? We have, this is the external iliac vein, and this is the internal iliac vein. I want you to see something. That's my hand holding the continuation of the internal iliac artery. The internal iliac artery anterior branch يدينا 10 branches, and then at the end it becomes the umbilical artery اللي هو infiltrated اللي هو become ligament. Okay, so I will show you now another one closer picture, but keep this picture in your mind. We are the same picture, we are closed now. So what we have here, we have now the external iliac artery, وتحته هنا external iliac vein. هذه اليوريتر literally jumping, literally تنقص كده بتطب في البلفس at the common iliac artery bifurcation. وبعدين بيجي عندنا الانترنال، طبعا ما هو واضح هنا البايفوركيشن حقت الكومن iliac لانها تحت. But this is the internal iliac artery, and this is the continuation of the internal iliac artery. Okay. So we tie the anterior branch of the internal iliac artery 1.5 to 2 centimeters away from the bifurcation of the common iliac artery, and to avoid the external iliac vein, we use the right angle from lateral to medial. يعني نجي من هنا toward inside. طيب, embolization. If the patient hemodynamically stable, yes, you can do the internal iliac ligation, especially إذا ما كانت البيشنت already عندها يعني incision والabdomen is open. So maybe you should do the internal iliac ligation, internal iliac embolization by the interventional radiologist. And nowadays they use it a lot الحقيقة في حالات البلاسينتا أكريتا والdifficult surgeries اللي anticipated. Hysterectomy. طبعا hysterectomy, it is something that we should يعني do at the end. After we try all the measures we mentioned earlier. لكن there is a catch الحقيقة. If you want to avoid the hysterectomy, be sure that a hematologist with you. طيب, هقول لكم ليش. طبعا hysterectomy احيانا نسويها if it is very extensive very massive bleed او extensive rupture. الرupture نفسه it is so bad that we cannot repair. This is a uterine rupture. هذه حالة عندنا كانت قبل 17-18 سنة. This is the fetus spine and this is the rupture. This is the uterus. وهذا البرود ligament. فالبيبي هنا في البرود ligament. This is the patient. This is the rupture. طبعا هذا bleeding ما وقف إلا لما سوينا bilateral internal iliac artery ligation. For junior staff, for residents, for fellows معانا, have these 2 books at your library. Have it. طيب. Unfortunately, this book is not available anymore. هو out of print. Willis is a gynecologist هو كتبه. لكنه حطه online. So atlasofpelvicsurgery.org, you can actually access the whole book online. Warning. Don't fight medical bleeding surgically. طيب. After massive bleeding. Massive bleeding عندي after massive transfusion يعني after the 6th unit of packed RBCs. لو المريضة أخذت 6 units packed RBCs, most likely there is a coagulopathy already. So you should really ask for frozen plasma and cryoprecipitate. طيب. If you want to do the test, that's fine, but maybe you don't have the luxury to wait for the test, so ask for frozen plasma immediately. And that was الشيت الكبير اللي وريتكم هو indicating that you should prepare these things من البداية. And it will be very bad. Patient is bleeding medically, and you are trying to correct that surgically. You can't. You will not. الشيء الثاني, for every year مرتين أو 3 try to have a drill of postpartum, massive postpartum hemorrhage in the labor and delivery, and you will see panic زي ما قال دكتور هشام. عارف? You see everybody is running everywhere without any efficacy. But if you have a system and you have a tray and you have a systematic way of approaching this drill and you do it again and again and again, believe me, you will save life. طيب. If you want to do anything surgically, anatomy. And I always joke with the resident لما ندخل معاي العمليات ما أعرف إذا في أحد منهم موجود هنا, أقول لهم دائما if you don't know anatomy, don't do surgery. طيب. If you don't know anatomy, تسووا أدب مقارن, تاريخ, قانون كويس. طيب. But don't do surgery. واحدة من الريزيدنت كانت very smart, قالت لي دكتور أو learn anatomy. فقلت لها والله that's a much better option. If you don't know anatomy, learn anatomy. طيب. دكتور سمير, do we have time in I show a short movie about anatomy ولا?
How much it will take time? Yeah, go on.
طيب.
2, 3 minutes, 4 minutes, it's okay. Because people are enjoying. Yeah.
I hope so. I hope so, دكتور. طيب. This is a robotic surgery. lymphadenectomy. ما لا علاقة بالبوستبارتم hemorrhage. I'm not crazy إنه والله بدنا نسوي robotic for endometrial for postpartum hemorrhage. لكن I'm going to use الكاميرا حقت الروبوت to show anatomy. ماشي؟ The whole idea is just to show you البلفس. في حالات الاندوميتريال كانسر وبتسوي لها lymphadenectomies. طيب. If you look here, you can see the round ligament, and this is what you usually tell the resident. If you want to visualize the ureter, go to the round ligament, 2/3 in, 1/3 out, open the round ligament, and after opening the round ligament, معلش دقيقة ما أعرف إيش شغال إيش. After opening the round ligament, cut the posterior leaflet of the broad ligament, parallel infundibulopelvic ligament, to visualize the ureter. طيب, we are opening the round ligament. طبعا احنا بنسوي تيوب لايجيشن في حالات الاندوميتريال كانسر عشان الكانسر لا يطلع، لا هذا ما له علاقه. فالان cutting الراوند ligament. After cutting a round ligament, we cut the posterior leaflet of the broad ligament parallel للinfundibulopelvic ligament. هذه في أي hysterectomy المفروض نسويها. طيب parallel للinfundibulopelvic ligament all the way to the base of the infundibulopelvic ligament. Opening the retroperitoneal space. طبعا هذه في حالات اللاباراتومي it will be very difficult to visualize لكن look at this now. You can see the right external iliac artery pulsating تحت السيزر. أنا opening the anterior. That's the external iliac artery in the right external iliac artery في اليمين وتحته right external iliac vein. You can see the vein. I'm opening still the retroperitoneal space and I will show you the ureter now in a second. The ureter will be yes بدأت تبان الآن اليوريتر أهي. You can see the ureter is running in the medial aspect. So after opening the retroperitoneal space, the ureter will be in the medial aspect of that broad ligament. طيب. Continue. That's the external iliac artery. الانترنال iliac artery حيكون تحت الفين. الفين حوريكم الفين in a second. أنا بس بفتح زيادة. هذه اليوريتر انتهينا منها. أنا بس هنا حاشيل الانفندبولوبلفيك ليجامنت. Now, look at this. This is the external iliac artery. جنبه نيرف صغير. Genital branch of the genitofemoral nerve. وحنشوف دحين بعد شوية external iliac vein. طيب. That's the genital branch of the genitofemoral nerve. أنا بشيل النوتس. Look at the vein. شايفين الفين؟ هذا الوول حق الفين. بسبب الاير بريشر الفين wall collapsing. So if you open it, it will be very difficult to repair. لأنه كل سوتشر حتحطها الفين كولابس بالاير بس. كل سوتشر تحطها هذا الفين وول. كل سوتشر تحطها راح تفتح زيادة فيه. Okay. That's the vein. That's the vein. I'm going in the obturator fossa. And that's the obturator nerve in the obturator fossa. If we cut it, the patient loses the ability to do adduction. It supplies the adductor group. Internal iliac artery تحت النود هذه بالضبط. هذه النود اللي أنا حمسكها الآن حوريكم الانترنال iliac artery. هذه اليوريتر. الآن أنا am teasing اليوريتر عشان تسوي لنا peristalsis. You can see the peristalsis. تحمس شوية قاعد بضغطها كل شوية. That's the peristalsis there. طيب الانترنال iliac artery حيكون away from all of that. When you put your right angle, I'm going to stop here. And we'll take questions if you have. Thank you very much. معليش أخذت شوية وقت. تسمعوني ولا؟ تسمعني هشام؟
Great job. Yes, I can hear you. Excellent حاتم. جزاك الله خير.
أظن سمير ما هو سامع.
سمير راح تتغدى ولا ايش؟
يمكن الانترنت.
والدني حاتم ما شاء الله تبارك الله. تسلم الايادي.
طبعا انا ما بقول انه ندخل بالروبوت في حالات البوست بارتم هيموريج. انا بس عشان الاناتومي عشان لا.
يعطيك العافيه.
طيب I think سمير يمكن.
No, I'm with you, but it's actually just only I want to say there are some questions. I'll go through it quickly. Thank you for your interesting lectures. Just only one question for Prof. Hassan Jamal. Is episiotomy considered a risk factor for postpartum hemorrhage, and your opinion in the medical practitioner about that one?
Okay, it's really a risk factor, number one. Number two, it depends on who's attending the delivery, because sometimes, للأمانة, they do episiotomy not in a good time, type of the episiotomy and the tissue, because as you know that there is a different opinion about primary gravida لازم episiotomy والثانية احتمال تحتاج. I think the attendants of the delivery who going to decide about she need episiotomy or not, number one, what type of episiotomy, is a midline or lateral. So it is a risk factor. Sometimes if you have a good sized baby and you do just small episiotomy, it might extend badly up to the rectum and rupture bladder. And they call me for some cases, very sad, للأمانة. Well, a good sized baby, there is no need to do a major episiotomy, and then you got a rupture vagina, rupture bladder, and it is a risk factor, but it depends on who's running the show during the delivery.
Thank you, Prof. Hassan. Actually, some of the participants, they are, thank you very much for your generosity, Dr. Hatim and Jeffrey, for your lecture, and that you will send it to them. They are asking if other speakers are ready to send it. I'll say this is actually intellectual property. It's up to the speaker. If they want to send it to us, we'll send it to them. So it's up to you, Prof. Hassan Jamal and Dr. Hisham Arab, about that one.
Absolutely. From me too, no problem.
It seems that all of you are so generous. So thank you very much for that one. And one question is for Dr. Hisham Arab, that when exactly to use recombinant activated factor 7 in postpartum hemorrhage?
As I said before, we do our routine workup and preparation. We give the medical treatment from cytosinon, prostaglandins, Pabal, do your massaging, even if you want to do a balloon. Actually, it's a second stage after if the patient is still bleeding heavily and we see that she's really affecting her fibrinogen level, whatever. Number two is sometimes maybe you can, for example, in case of cesarean, you can go on with the Birch procedure, the B-Lynch procedure or any other technique to help reduce the bleeding. So really, you can say it's the last resort. Okay, when we start to think, well, we did what we can, but maybe there is an area here that can be helped with the Novo 7. So that's the indication, I think, for it. And I said before, you have to do all the like the laboratory workup and also get the advice from hematologists nearby.
Thank you very much. Just I'll add that according to drug information system, that as you said, that in cases of severe postpartum hemorrhage, Nova-7 is indicated for the treatment of severe postpartum hemorrhage when the uterotonics are insufficient to achieve hemostasis, and treatment should be initiated under supervision of physician experience in the treatment of hemophilia and bleeding disorders. Just I want to say that both actually the dose, as you said it, that the recommendation dose, the range is 60 to 90 UJ per kilogram body weight, and it's administered intravenous injection. On the same time that the Blood Disease Society and Women's OD Society, they are going to do a guidelines for the use of factor 7. It's going to be actually published. We think in the next 6 months, it's going to be ready, inshallah, even before that.
Good. That's also, we are going to highlight in this discussion about the role of the hematologist and the management of the severe postpartum hemorrhage. In some hospitals, they got a hematologist. So don't hesitate to call somebody who could help also you that to decide which drugs you have to give according to the investigation you do. Definitely, it will be a teamwork, so the prognosis will be better, definitely.
Yes, definitely, and I think it's a teamwork. So it's actually being a teamwork, it will help to reduce actually the morbidity and mortality. One question to Dr. Hatem Al-Jifri, how we should ligate internal iliac artery? Does we need to call the vascular team?
I really think maybe you don't have the privilege of having a vascular team in your hospital. Ligating an internal iliac, it's really not a big deal. To be honest with you, it's anatomy. And always I tell the residents, for every single simple hysterectomy, cut the round ligament, cut the posterior leaflet of the broad ligament, افتح retroperitoneal space, visualize the ureter, and move with your finger down the common iliac bifurcation, and you will see the internal iliac. If you do that in every simple hysterectomy, حتى البناين يعني أقصد, believe me, it will be a habit. It will be very easy في الحالات difficult that you can visualize the ureter. It's a very simple procedure. وبعدين بالمناسبة يعني all what you need to do حتى you don't need to cut anything. يعني حتى chromic, tie with chromic, وبعدين هي will be absorbed يعني.
Definitely.
هذا الجمري يا حاتم. كروميك يا حاتم. على زمان انا.
ايوه بالضبط. وترى مو كل واحد يريد انه هو يتريند ولا يعمل ديسكشن. انا خاف من النقطه هذه، يعني بيتر انه هو لا يدخل.
ايوه صح
وكذا للامانه، يعني ما يكون هو فعلا ويل تريند، يعمل دمج اكثر وكذا يعني.
صحيح.
Thank you very much for your actual participation. I'll leave for each speaker 1 or 2 minutes if you want to talk anything. So please give us, because we have shortage of time and we can't go through all the questions. So Prof. Hassan Jamal, if you want to add anything in 1 or 2 minutes.
Thank you so much about this meeting. I would like to concentrate on the ABC management of the postpartum hemorrhage. As you can see, therapy, lots of advanced, لكن implementation ما في. أنا يعني كل اللي يمكن شفته في اللجان وكده حاجات very simple. لا في blood ready للpatient، لا في يعني لا blood ولا drugs موجودة ولا early diagnosis. كلها late until the patient going down and they will call us. Please try to have a good training for your staff, whether they are a doctor, they are a midwife, and hospital administration. They should know that أنا ما أبغى أجي فترة أطلب أكسيتوسين يقول لي والله not available، إرجومترين ما هو موجود، والله هذا ناقص في major hospital، فما بالك بالده. فأنا برضو أرجع وأقول، وزي ما برضو هشام ويعني حاتم قالوا ABC management is very crucial. الثاني إحنا بنقول فاكتور 7 وهذه بيقول لك طب أنا ما عندنا فاكتور 7 في المستشفى، ما عندي هذا. ABC لو راجعنا كلنا التحقيقات كلها في اللجان والله كلها ABC وليست a major issue. Thank you.
Thank you. دكتور هشام عرب.
أنا أعيد وأكرر شكري لكم جميعا والفرصة السعيدة هذه. In fact, yes, it's absolutely important to consider the multidisciplinary approach to cases of PPH. I think you should suspect PPH in every single delivery, even when you're doing cesarean and you see a little bit more blood there coming. And once that suspicion came up, you should really initiate an alarm where at least you can go back again and check other things that, for example, blood availability and even expertise availability. So these people or these things may take some time to be available. So at least you go, just try to be ahead of the situation. And تمنيت لكم إن شاء الله يعني أخبار طيبة ونبعد عننا المشاكل والcomplications هذه.
دكتور حاتم الجفري. Thank you دكتور هشام.
شكرا جزيلا. one message، لأنه في بروجرام دايركتورز كثير معانا، head of departments كثير معانا. Please after we finish go to your department, create a DBB and create 2 sessions of simulations. We can help you in writing scenario for simulations. ما يحتاج instruments. You don't need to buy anything. You don't need to buy anything except إنك أنت you create a scenario of simulation وتسوي drill. You will be surprised how your efficiency will improve after such يعني couple of simulation sessions إن شاء الله.
Thank you very much for that one. All the participants, they are sending in the chat. Thank you very much for all the lecture. It's very informative, and none of them, it seems that they are leaving, whether in the YouTube or in the Zoom, more than 1,400. So I'd like to thank all the participants. I would like to thank Top House Conference. I would like to thank Nova Nordisk for their support, and we hope that we'll see you again and again for interesting lecture. Thank you very much for all of you for your generosity, because giving the lecture to all the participants will send it to them, inshallah. Thank you very much, everybody. وجمعة مباركة.
جزاك الله ألف خير، والله يجعله في ميزان حسناتك دكتور سمير، وكذا ويبارك في علمك وعملك إن شاء الله.
الله يسلمك.
شكرا، جزاك الله خير.
مع السلامة.
شكرا.